So I get the privilege of speaking to you today from my perspective as a medical oncologist. So just another review. So unfortunately, as we've heard, there's about 135,000 new cases of colorectal cancer diagnosed in 2015, and of those, about 45,000 deaths. The good news is, as has been discussed before, the incidence, as you see on the left, is declining in both distant disease and localized disease. And on the right side, you see that the survival rates are increasing. So this is all very important and good news. And research suggests that these declines are due in large part to most notably modifying risk factors, number one, and number two, screening and polyp removal in terms of preventing the progression of polyps to cancer. Screening is also very important in terms of detecting cancer at an earlier and more treatable and curable stage. And then, of course, colorectal cancer treatment advances, which is where I come in. So here's a graphical representation of the trends in colorectal cancer mortality. And what I want to point out, if I can, here we go, is that the grand majority of the decrease in the mortality is because of modulation of risk factors. So 9% of the decrease comes from risk factors modulation in terms of decreasing the amount of red meat, increasing exercise, decreasing obesity rates, and also a large majority, as was discussed by Dr. Pachapin, of screening, so with colonoscopies or other methods of screening modalities. So these two things are sort of give us the biggest bang for our buck in terms of lowering the risk of colorectal cancer mortality. And then comes in the treatment where I come in. So that has led to some advances, but of course that is much less than modulating risk factors and screening. So just again, in terms of how colorectal cancer develops, so it was spoken about before, it starts as a polyp and progresses to cancer. And during that progression, there are stepwise changes within various genes, both cancer-promoting genes and tumor suppressor genes that occur that allow this small polyp to eventually become a cancer. So a lot of different things are occurring. In terms of staging of colon cancer, you all may have heard of the TNM staging. And so we look at a colon cancer based on the depth of penetration through the wall of the colon, whether it goes through the mucosa or the muscle layer or all the way through the colon wall. So that's the T stage. And then we look at the N stage. So how many regional lymph nodes are involved when the surgeon removes the colorectal cancer. And of course, M is if there are distant metastases, such as in the lung or liver. So when we look at stage at diagnosis, you can see here that about or more than half of patients are diagnosed between stage 0 and stage 2. So that's excellent. So they have been caught early and have a very high cure rate. In terms of stage 3, those are patients with nodal involvement of their colorectal cancer. About a quarter of patients are diagnosed at that stage. And then we have about 20% of patients who are diagnosed with advanced colorectal cancer. And what's important about what staging informs us is survival rates. So this is, again, on average, but what we see that when patients are found to have early colorectal cancers in stage 1 and 2, they have about a 90%, 80 to 90% survival with surgery alone. So these patients are generally cured, and these are the patients that I don't see in my practice. The patients here with stage 3 and stage 4 have a lower cure rate, albeit it varies anywhere between 40 and 70% for stage 3 colorectal cancer patients. And then with stage 4, this is a moving target. So what are the goals of treatment? So treatment is defined by stage and the type of cancer present, whether it's colon or rectal. Goals for treatment of early disease include removing the cancer cells completely with surgery, killing the cancer cells with chemotherapy, and keeping the cancer cells from returning. In terms of goals for advanced disease, what our goals are is to slow or stop the growth of the cancer cells and manage the quality of life and symptoms of the patients. So what do we use for treatment? So as has been discussed, surgery is really the mainstay for localized colorectal cancer. Radiation is often used in rectal cancers, chemotherapy, and then there are clinical trials that are looking at experimental medicines, and of course, complementary therapies are very important. So what affects our treatment decisions? So certainly the type and stage of the disease, the specific genetic makeup of the colorectal cancer, the age of the patient and the patient's overall health. Do you have diabetes or cardiac disease? Whether or not you've had any other cancers before, and what types of cancer treatments you've had. Those are important things in making decisions. And then your willingness or ability to tolerate certain side effects are discussed, because different chemotherapeutic agents have different side effects. The ease and convenience of treatment, we have intravenous medicines, and we also have oral medications. And so together, we come up with a plan. And then, of course, we can't forget insurance and costs, because there is certainly financial toxicity to cancer treatment. So how do we define progress in the treatment of colorectal cancer? So, of course, new and more effective drugs are important. So is new adjuvant therapy, which can enhance cure rates, and then new therapy for metastatic disease in terms of prolonging life and controlling disease symptoms. And of course, understanding what really drives the cancer so we can find new targets and develop new treatments is very important. So what is adjuvant treatment? You may hear this term. Adjuvant treatment reduces the risk of recurrence. And the theory is that the metastatic cell is the one that got away. So in a localized cancer that is removed, there can be this one cell that escapes, so to speak, and goes out and extravasates into the bloodstream, and then circulates in the bloodstream and settles in the liver or the lung, a distant site that later can lead to recurrence. And so how do we target the cell that got away in terms of adjuvant or risk-reducing treatment? So standard adjuvant treatment in the United States for colon cancer is for stage 3 patients. So those are patients that have cancer in their lymph nodes at the time of surgery. And treatment is standardly 6 months of chemotherapy with either a fluoropyrimidine drug or a combination of a fluoropyrimidine and oxaliplatin. So you may have heard of something called FOLFOX as the abbreviation, or capecitabine, 5-FU, or a clinical trial. And what you'll see here is with surgery alone, on average, there are nuances to this, but on average, with surgery alone in a stage 3 patient, the 5-year survival is about 44%. And with chemotherapy, single agent, we can bring that up to 60%, and with doublet chemotherapy, up to 70%. So you see that with the 6 months of risk-reducing chemotherapy, we are targeting those cells that got away and leading to increased cure rates. In terms of stage 2 disease, where there are no nodes involved, typically we do not offer chemotherapy to reduce the risk because the cure rate is so high, but there are certain instances where it may be offered. Turning to rectal cancer, the standard treatment for risk-reducing treatment for rectal cancer is only offered for those patients who have a T3, so a tumor that's penetrated the muscle layer of the rectum, or have lymph nodes involved. And typically we use neoadjuvant treatment, which is treatment before surgery, and that involves chemotherapy and radiation. In the cases where patients have had surgery prior and they're then found to have positive lymph nodes, then we may use postoperative chemotherapy and radiation. And certainly there's always the possibility of a clinical trial in this situation. So do we know how much therapy do we need? Because, 6 months of treatment after surgery is not insignificant, and we all appreciate that, and there are certainly toxicities during that time. So nationally, what's been looked at is whether we can decrease the amount of therapy, the duration of therapy, that is. And so what was just completed was a national study in over 2,000 patients in the United States looking at 3 months of treatment versus 6 months of treatment. The results are not yet in, but this will be a very exciting study when it reads out, because if 3 months are non-inferior, just as good as 6 months, then we can avoid a significant amount of toxicity while still curing many, many people. So the other national study that's ongoing and is open here at NYU that we're looking at in rectal cancer is whether we need radiation for all rectal cancers, because if we can spare that toxicity to patients, that would be wonderful. So this is an ongoing study looking at preoperative chemotherapy, and for those patients who have a good response in the rectum, then they go straight to surgery and avoid radiation. And so when this is over, we'll anxiously await those results and see if we can get minimize toxicity. So now let's turn to metastatic disease. So there's really been 3 eras at this point of colorectal cancer treatment in the advanced stage. So from the 1960s to the 90s, it was the single agent 5-fluorouracil era. And during that time, there was a lot of different modulation, different ways to give this drug. Until the mid-90s to 2000s, when additional chemotherapeutics were developed and were combined with 5-fluorouracil. And then in the 2000s to now, we are in the age of the targeted agent era, so more personalized medicine. And where we're entering now is really the age of molecular selection and then immuno-oncology. And I'll talk a little bit about that. So what you see listed here are the current FDA-approved agents for advanced colorectal cancer. On the left, you have sort of the standard chemotherapeutic agents, including 5-fluorouracil, capecitabine, which is the oral prodrug of 5-fluorouracil, irinotecan, oxaliplatin, and the newest kid on the block, TAS-102, which was just approved a couple of months ago. And then here on the right side, you see the targeted agents, cetuximab, panitumumab, bevacizumab, aflibercept, regorafenib, and ramucirumab, a mouthful. And certainly these have all been developed in within the last 10 years. And the way we use this, I liken to a chess game, because it's a lot of moving pieces and combining different drugs at different times to manage toxicities and to manage the disease course. So here's sort of a timeline of the various drugs, and also what you'll see here is also the survival rates in advanced disease. And so where we had 5FU alone, we were talking about survival rates between 6 and 12 months for advanced metastatic disease. Now we're approaching 3 years. So we've certainly made progress, but there's a long way to go. And what you can see is just here are the kind of standard cytotoxic chemotherapies that we think about when most people think about chemotherapy. And then these drugs in red are the VEGF inhibitors, which work on blood supply, and I'll talk a little bit about that, targeted agents. And then the drugs in yellow are the EGFR inhibitors, and I'll go through their mechanism of action. So targeted therapies. It's a step towards the development of a personalized medicine. And really, all cancer treatments have targets, but some targets are more broadly expressed in the human body. And therefore, when using that targeted treatment, there's more side effects. And then some targets may not be expressed in an individual cancer. So we really need a smart bomb, not an atomic blast. And here's a depiction of what we know about what what goes on in all cancers, but in colorectal cancer as well. And there are multiple areas that are disrupted, including blood vessel growth, genome instability, mutation, resistance to cell death, and et cetera. And I won't go through all of these, but what is most developed and in practice right now are, as I mentioned before, inhibitors of blood vessel growth and epidermal growth factor receptor inhibitors. So what is so important about blood vessel growth for tumors? So this is a little bit of a depiction of a small tumor without blood vessel growth. And in order to grow to be of substantial size, it needs to kind of take over and co-opt the blood vessels for its own nutrition and oxygenation. And until this occurs, it really is not going to get it's not going to grow from a small tumor to a large tumor. So this is an important mechanism that's been shown in tumor development, the angiogenic switch. And there are multiple drugs that are now approved targeting angiogenesis, including antibodies such as bevacizumab, soluble VEGF receptors like aflibercept, a very newly approved drug, ramucirumab, which targets the receptor, and then small molecule oral medications that target the intracellular receptor. The problem with these drugs, while they're targeted, we don't have a biomarker of who is going to respond to them. So we use them rather indiscriminately. And that's something that's being investigated about who would respond rather than using this for everybody, because they certainly do have toxicities. So in terms of personalized medicine, how can we improve on targeted therapy? So I think this is a nice depiction of what we're trying to move towards. So we have a population of colorectal cancer patients, and we'd like to have a diagnostic test that if you're positive, then you're likely to benefit from the treatment. And if you're negative, you're going to be unresponsive and therefore spared the toxicity and cost of that treatment. So the epidermal growth factor receptor inhibitors are an example of this. So EGFR is overexpressed in colorectal cancers, and its activation can promote cancer growth through what's called the RAS-RAF signaling pathway. And there are monoclonal antibodies, such as cetuximab or panitumumab, which have been developed and can block the activation of this signaling pathway. And what was shown back when they were first introduced was that single-agent responses are about 10 to 15%. So not great, but there's something there. So who gets the benefit? Who are those patients, the 10 to 15%? So this is looking at the signaling pathway. And so what happens is the epidermal growth factor sits into this receptor and signals downstream, and these drugs can block that signaling. However, what has been shown is that if there's a mutation in these genes called RAS or RAF, it doesn't matter what you do outside of the cell, it will just keep signaling because these genes are turned on constantly. And so what we've learned is how to integrate oncogenesis with treatment. So we've found that RAS and RAF mutations, changes in those downstream genes, are predictive for response. And so this is an early event in the development of colon cancer. And it's an oncogene which turns on the signaling cascade in the cancer cell to promote growth. And it's a pretty common mutation. It occurs in anywhere between 50 and 60% of colorectal cancers. And what we have learned over time is that those mutations confer resistance to these medicines, these EGFR inhibitors. And so we now know not to use cetuximab or panitumumab in colorectal cancers that have RAS or RAF mutations. And this is just an example of how we learned that, looking back. So here this is a survival curve, and these are patients with advanced colorectal cancer who were treated with either best supportive care, so placebo, or an EGFR inhibitor, and you see there's no difference in their survival rates when they're unselected. However, if you look at just RAS wild type, meaning not mutated colorectal cancer patients, you can see that giving the EGFR inhibitor does lead to much greater benefit. And so patient selection with molecular classifiers is so very important. So as I said, molecular profiling, extremely important. It's really lets us know if a treatment will work, and it avoids unnecessary time and a cost of ineffective therapy. It also avoids the unnecessary side effects of ineffective therapy. And what we've also seen is that it can avoid treatments that could actually make your cancer worse. So not only does it not work, but it can make things worse. So it's very important to make sure that your oncologist tests for this molecular profile. So now, what are some other targets? I've spoken about the angiogenesis pathway and the EGFR pathway, but are there other targets that we can look for in colorectal cancer that we can develop drugs against? And here's sort of a complicated and busy slide, but to show you that there are a lot of different areas that we can target and that we are targeting in clinical trials to halt the growth of colorectal cancer. But as complicated as that is, that's really just the tip of the iceberg. And really what cancer signaling looks like is more like something like this. It's a very intense network, and when you interrupt one area, there's a rebound effect in others, and there's lots of crosstalk. So it's not that simple, and interfering with one area can certainly have unintended consequences on others. So just to give you a little idea of the complexity and why we aren't making even more advances than we have. And then finally, I just want to touch on immuno-oncology, because I'm sure you have seen the significant advertisement for other cancers where some of these immunotherapies have been approved. And so certainly in the colorectal sphere, they are being looked at. And to understand, the immune system is a very powerful system in our body, right? And it fights infection. And what's interesting about the immune system is it knows how to shut itself off, right? After you have an infection and it's contained, your immune system dampens down. So there's a lot of checks and balances within the immune system. And so the immune system can also detect cancer cells. But the interesting thing that's been noted is that cancer cells can co-opt that checkpoint and are able to evade the immune system and shut down the immune system. And there have been drugs developed which interfere with that immune evasion. And so these drugs are being now looked at in colorectal cancer. So, am I not advancing? Here we are. So unfortunately, in the initial studies, and this is just a group, some titles from various manuscripts showing some of these immune checkpoint blockade drugs in colorectal cancer, and they were very disappointing. Response rates of 0 out of 18 patients, 1 out of 14, 0 out of 19, a very unimpressive showing compared to other cancers like lung cancer where it's been approved. However, what has been most recently noted, and I will say this is just very early data, immune therapy is not yet approved for colorectal cancer, but we're beginning to see who it may work in. And what's been noted is colorectal cancer patients with a mismatch-repair defect. And so mismatch-repair genes are genes that help repair errors in the DNA. And so some patients, up to 15% of colorectal cancer patients, have defects in the mismatch-repair genes. And so these patients are more likely, it seems, to respond to these immune checkpoint blockade inhibitors. So what you see here is responses. So going down is good. That means the tumor got smaller. And so in these very refractory colorectal cancer patients who had received all those FDA agents that I had shown you, they're showing response rates of about 40%. And what you can see here is the survival curve in the mismatch-repair deficient patients, where this is unprecedented. So this is very early, exciting data. Again, not yet approved, and is going to be it's being tested in much bigger studies. This is early on, only about 20 patients or so. So we look forward to incorporating immune oncology into the treatment of colorectal cancer in the future. So I just want to sum up. Colorectal cancer is a very common disease. It develops with numerous stepwise genetic changes. There certainly have been treatment advances in increments over the last several decades with lots of new drugs. Treatment's really stage specific, right, and involves a combination of chemotherapy, surgery, radiation. We're at the beginnings of molecular personalization and immuno-oncology. We have a long way to go. And I should say personalization also is important, not just about molecular personalization, but also about personalizing to each patient, right? Considering the patient's goals, their preferences, their comorbidities, and their functional status. It's really got to be a conversation. And then I think it's really important to always consider and offer clinical trials, as that's really one of the best ways that we can advance cures. If we're not curing 100% of patients, then we have room to go, and therefore I really encourage enrollment in clinical trials if there's something that is appropriate. And so I just want to leave off and say thank you, and remember, colon cancer, preventable, number one, treatable, and beatable. Thank you.